Morning. I'm going to call to order the joint CERS and KRS Retiree Health Plan Committee for May 13th, and we're going to begin with an opening video teleconference statement.
This is a regular meeting of the County Employees Retirement System and the Kentucky Retirement System's Boards of Trustees Joint Retiree Health Plan Committee. This meeting is being broadcast via video teleconference pursuant to Kentucky Revised Statutes Section 61.826 and may be viewed by the public at the Kentucky Public Pensions Authority offices at 1260 Louisville Road, Frankfort, Kentucky. It is also being broadcast to the public via Facebook. If you are speaking and are not appearing by video, please identify yourself before talking. Please ensure that you are on camera when making or seconding a motion or casting a vote. In the event the video or audio broadcast is interrupted, we will attempt to reestablish a connection. If a connection cannot be reestablished within 30 minutes, the meeting will be adjourned and rescheduled to another date.
Thank you. Roll call.
Yes, sir. Mr. Piercy?
Here.
Dr. Carver?
Here.
Mr. McGraw? And Mr. Riley?
Here.
Thank you.
Okay, we have a quorum. Public comment, Sherry?
No, sir, no public comments today.
Okay, next item is the election of both a chair and a vice chair for this committee for this board year. And I'll seek nominations first for chair. This is where the Jeopardy music again is supposed to play. I think I said that at the last meeting.
Sherry, please play it.
Well, it's going to be, it looks like it's going to be vacant for the year.
I'll nominate Keith Piercy.
Okay, we have one nomination. Any further nominations? Something tells me I shouldn't wait very long for a second nomination. Okay. So nominations are closed, and is there a motion to approve myself as chair of the Joint Retiree Health Plan Committee for this year?
Motion.
All right. Is there a second?
Second.
Okay, any discussion? Seeing none, all those in favor?
Aye.
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 Any opposed? And that motion is adopted. And now I'll seek nominations for the vice chair position. I'll nominate Dr. Carver from the chair if I'm allowed to do so. I think I can. You accept that, Dr. Carver?
Yes.
Okay. Thank you. Any further nominations? If not, I'll seek a motion to approve Dr. Carver as vice chair of this committee for the next year.
So moved.
And I will second. Any discussion? Seeing none, all those in favor?
Aye.
Aye. Any opposed? And that motion is adopted. So we have the elections out of the way. The next item is the approval of committee minutes from February 12th, and I'll seek a motion for that.
So moved.
All right, we have a first. Can I get a second?
Second.
Okay, first and a second. Any discussion? Seeing none, all those in favor?
Aye.
Aye. Any opposed? And that motion is adopted. And our next item is the account management review, and we have folks from Humana with us.
Yeah, sure. If you can go to the next slide. Well, congratulations on the re-elections for the next year. My name is Joe Coles. I'm from Humana. We're here today to discuss kind of the experience from 2025, as well as some key items from 2026 and 2027. With me in the room is Gabe Hellinger, who's your Senior Account Executive On the phone, we have Stephanie Heller, who is the Director of Account Management. She's a little bit under the weather. And then Carrie Lovell, who's traveling, who's your pharmacy lead. So first of all, I want to say thank KPPA for their long-standing relationship with Humana. I think you're one of our largest and most long-standing customers, and we appreciate the opportunity that you've given us to cover your retirees. We don't take that lightly. It's something that we care deeply for, and it's something we want to do into the future. We'll go on to the next slide. So I will say our slides are a little different than the agenda. We'll cover everything, but just a note. So every year, CMS issues a advance and final notice, and what that is that's official communication from CMS that talks about the rules, regulations, and payments for Medicare Advantage carriers for the next year, in this case, 2027. You'll see here, and I always have a hard time seeing, that the final notice gave all Medicare Advantage payers a additional 2.48% average increase in payment. So that was a little less than the prior year, but was certainly better than the advance notice, which is essentially flat, which was 0.09%. The one thing we would note is it still represents some headwinds because medical and pharmacy trends are still in advance of the 2.58%, as you guys well know, sometimes in the low single digits. Something else to note on this is they did keep the risk score in place. There were some discussions about changing the risk score methodology. They decided to table that. And the only thing they put in place is something called a regulatory change around unlinked chart reviews, which is basically wanting to tie a retrospective chart review to an actual clinical encounter. You guys may have read in the paper, sometimes there's been some discussion about making sure that the risk score was representative of a clinical encounter and that people weren't just doing retrospective chart reviews to gain more revenue on risk score. So a regulatory change around that. It's actually something Humana recommended to CMS as we look to make Medicare Advantage more efficient. I think we're trying to be a leader in that space with our relationship with with CMS, and so that's actually something we recommended that CMS took. I'm trying to make sure I can see. Another thing that was changed was the star ratings, and as you guys well know, stars really are a CMS program that represents quality and efficiency and member experience of care. They made some changes. Currently, the star ratings include a lot of administrative and operational measures, how fast you answer the phone, those types of things. What CMS discussed here is, and this will impact people in 2029, Medicare Advantage carriers in 2029, is really removing some of the administrative and operational measures and focusing more on clinical and member experience. And so now the star rating might be, is a Medicare Advantage carrier getting the member to get their A1C test? So are they able to get them to get that, a member with diabetes? What they're proposing, and this would go into effect again in 2029, would be can that Medicare Advantage get that member to improve their A1C? So actually improving the clinical measure, not just getting them to take the test. And so that's a big switch. And so I know all the Medicare Advantage carriers in the industry is working to do that. But it certainly makes sense as you move the program forward to really, if you really want to focus on quality and clinical, it makes a lot of sense because answering the phone is, you can answer the phone, right? You can just throw more people at that. And so I think this makes a lot of sense, but certainly going to require a lot of change, a lot of different approach for Medicare Advantage carriers as they work with their retirees who have these clinical conditions, gaps in care, to get those tests done and then improve them. The other thing, and I think this is actually something that's been pretty interesting, is the GLP-1s, and CMS and President Trump made an effort to make GLP-1s accessible to Medicare and Medicaid for lifestyle, meaning weight loss. Currently, most people take GLP-1s in the clinical space for diabetes and other clinical things. Currently, GLP-1 weight loss is prohibited to be covered under Medicare and Medicaid. So Dr. Oz and CMS and President Trump tried to put something together for 1/1/27 that would cover them under individual Medicare plans and group plans. Unfortunately, the industry and the rules that they set place for that plan, there couldn't be an agreement. So there was a plan in front of that, which was called the Bridge Program, which was a short-term demonstration program that would have, where the CMS will pay for it. GLP-1s were meeting certain clinical criteria, basically BMI and a certain clinical criteria, where a member could get that for weight loss for $50 a month. Because they couldn't come to an agreement with the industry, essentially what CMS did is they extended the Bridge Program, which was the short-term demonstration program, which starts in July of 2026, all the way through 2027. So that's an 18-month demonstration program where CMS will pay for GLP-1s, and the member has a $50 copay, cost share per month, for weight loss, provided they meet certain clinical conditions coupled with a BMI. So what's interesting about that, and why that's kind of, as we've been talking to our customers, and they've been super interested in that, is that there will be members of KPPA, there will be members of a lot of our customers who will do this program, participate in this program. It is outside of Medicare Advantage, it is outside of Medicare Part D. So they will do this, and they will pay the $50. Certainly if you do it today, you're doing it, it's much more expensive, right? So this is a significant discount on what the GLP wants. So the concern we have, and it's not really a concern, but we don't know the future. We don't know what's going to happen in 2028. So will this program continue? What will happen? Because presumably, if a KPPA member decides to do it this summer and is on it for the next year and a half, that $50 payment would end at the end of 2027. And so then we have questions, where will that leave the member? What will happen? And so I don't think we need to worry about that much right now, but it is something that we're thinking about because it's a demonstration program, there's no guarantee it will continue. And so it's just something we're thinking about and talking about. The only other thing I would note is on the MOOP, the Part D did go from 2,100 to 2,400 for 2027. Yeah. And so that's again, that's part of the IRA. So I think that's all I have. Any questions on this is kind of the federal regulatory update, what's going on, what's happening. Any questions?
Well, maybe just the IRA really benefited the member.
It
right?
did.
So just maybe go through a little bit of that history.
Sure. So Carrie, do we want to, Ryan's all over these slides here. So this is the next slide, Sherry. There we go. There you go. And so Carrie, you want to take over here?
Yes. Can you all hear me okay?
Yes.
Great. Great anticipation of what's coming next. So here you're going to see that over the past few years, we have really been closely tracking the impact of the Inflation Reduction Act on pharmacy benefits. And this slide gives you a really good snapshot of where we've been over the past few years with it and where we are today. We have talked before about what happened in 23, 24, 25. And so today we kind of want to focus on this right-hand side of the slide and look at the key highlights for 2026. What we see here is the increase of that MOOP from $2,000 to $2,100 for 2026. There were 10 Part D medications launched in the price negotiation program. There was a maximum fair price parameter added to the insulin cap. And then at Humana, we're just continuing to monitor legislation related to this so we can help keep our clients informed. If we move to the next slide.
So Ryan, we'll get to your answer right here, but real quick, at a high level, is we need to remember that the IRA reduced the MOOP from 8,000.
Yeah,
this is what Ryan was after.
Previous slide?
Yeah. And this is what Ryan was after, Carrie, and this will just help it flow, is the MOOP prior to IRA was $8,000. And so a member had to pay that $8,000 before they would go in the catastrophic phase. And they reworked IRA, so now the MOOP is $2,100. And the backdoor math on who pays is significantly changed as well. So Carrie, do you want to just go over that real quick to set the stage for those next slides?
Sure, Joe. Go over the math.
Yeah, just go over the 8,000.
Okay.
And yeah, go over the math and just explain.
Previous slide.
Yeah.
So when the IRA MOOP, the $2,000 MOOP took effect, it wasn't just including what the member paid out of pocket. The member, anytime they fill a prescription up to that defined standard deductible, which I think was $590 for 2025, $590, the entire cost of the drug applied up to that point. So not just what the member paid out of pocket, but that whole defined standard, not $590. So $590 counts toward that $2,000 right off the bat. Once they meet the $590 in drug cost, then there is a formula that gets applied behind the scenes that subtracts that $590 from the cost of the drug and multiplies cost minus $590 times 25%. And then the member is credited toward the greater of that calculation or their actual cost share, their copay on their plan. So what this resulted in, and I know that was a lot of complicated math, but what it results in is the members are not necessarily paying $2,000 out of their pockets, okay? They can hit the IRA MOOP because of the way that the costs are calculated behind the scenes, incorporating a portion of that total drug cost. So more than just what they truly pay out of pocket gets factored into this $2,000 MOOP. Now, if you look at the slide that we have in front of you, what you're going to see is a significant year-over-year increase in members hitting the catastrophic phase. And what we really want to hone in on here is kind of looking at that fourth quarter of 2024 and compare it to the fourth quarter of 2025. In Q4 of 24, 6.5% of members reached the CAT phase by the end of the year. And that number soared to 24.4%. Almost 4 times as many members for our group Medicare book of business hit the catastrophic phase in 2025. So in 2024, 6.5% reached a point where they had no further expenses. In 2025, 24.4% of our group Medicare members hit that catastrophic phase. So the IRA $2,000 MOOP had a significant impact on the way that the benefit laid out for the members. Even by Q2 of 2025, if you look at that, almost twice as many members had already hit the catastrophic phase as had hit it for the entire year in 2024.
Yeah, and Carrie,
so
it basically represented a significant benefit enhancement, and I think that's what Ryan was trying to get to, from an 8,000 prior to IRA, and of course IRA was put in place primarily for individual Medicare because they had gaps in coverage, and individual group Medicare coverage has always been very comprehensive. Every group customer we have has very rich pharmacy benefits, and so in this case, it actually further enhanced the richness of the group Medicare pharmacy plans, the CMS IRA.
And that's what we're going to see on the next slide. We're going to see the specific impact to the member out of pocket. So here you're going to see, this is again for our Humana Group Medicare book of business. In 2024, on average, members spent $950 out of pocket. That average member spend for 2025 was $476. And this was a direct result of that enhancement that Joe described. For KPPA, the numbers were very similar to what you see here. In 2024, KPPA members spent $861. And in 2025, it was an average of 458. So about a 50% reduction in that member spend resulted in a much richer benefit for the member and a much higher plan cost share. And so this is why we're starting to have conversations, as Joe mentioned, with our clients about sort of rethinking and restructuring some of the pharmacy benefits, just to return that member share back to that pre-MOOP level, because the benefit got richer just as a result of the Inflation Reduction Act, not because of a decision that anyone made. It was just an outcome of this act. We can move on to the next slide.
Okay, so here, thank you, Carrie. I'll speak to the, and this is Gabe Hellinger, by the way. I'm going to speak to the executive summary for the premium plan and the essential plan. Starting with the premium plan executive summary we see here. Average membership, not a lot of change year over year. Where we do see some change is the total net paid per member per month was an increase near 10%, 9.99%. With pharmacy net paid PMPM 16.3% above year over year. So seeing increase with plans net paid overall for both the medical and pharmacy, most of that increase in the pharmacy. While the specialty net paid is also up 24% as well year over year. So increased cost for the plan is what we're seeing a lot on the premium plan. Moving on to the next slide. We see the premium plan pharmacy here, and Carrie, I don't know if you want to jump in and speak to any of these numbers.
These numbers really just reiterate, Carrie, you can jump in, really reiterate your prior slide. When you look at the total net paid and then you look at the member paid PMPM, you guys can see the difference. Carrie, do you want to add any commentary there?
Yeah, that's really the story. The numbers that we saw for 2025 are unprecedented in the way you see that the cost shifted in that decreased member paid PMPM versus the increased plan paid PMPM.
And that's a story we're seeing across the board with all our customers. So this is not unique to KPPA. No one's doing anything wrong. This is just, again, really a product of the IRA and the reduction of that move to 2,200.
We can move on to the next slide with the essential plan executive summary. You can see this is a little bit leaner of a benefit than the premium. So the numbers do differ, not quite the increases what you're seeing, but you are seeing some, especially with the specialty net paid and pharmacy net paid, they are in line with those increases that we're seeing across the board with your all's premium plan members, but also across our book of business as well. So these numbers are in line with peer. But again, it's just those increases in costs that we really want to highlight here. Same thing to Carrie's point on the increase of what we're seeing on the essential plan as well. Okay, the member by phase report, and then Carrie, I'll lean on you here to kind of speak to this as well and add some.
Yes, Sherry, next slide, please.
Yes, next slide. Thank you.
There we go.
So this is a more detailed breakdown of what we discussed earlier. This shows you specifically KPPA members. The data we saw before was for Humana's group Medicare book of business, but this is specific to KPPA. And it shows you month by month how your members moved through the phases of the benefit. What you will see here is 3.6 times more KPPA members hit the CAT phase in 2025 compared to 2024. You had 31.3% of your members hit that catastrophic phase by December. And compared to our group Medicare average, only 26.9% of members across our group Medicare book hit catastrophic phase by December. So you hit it at even a slightly higher rate than our average.
And that's to our members' benefit.
100%.
Yeah, that's
Right.
for me. That's
Yeah,
to their benefit.
Yeah. Members won in a big way, and they're winning again this year. So, yeah.
Yeah, to reiterate that point, I think this next slide really, shows that you show your plan paid increase like we showed earlier, almost 10%, where your member paid has decreased. So that almost the same percentage as well, 9.2% decrease for what member paid. So to your point, the member, is winning in a lot of ways with the current benefit design.
Yeah, I mean, in the way this goes, guys, is a member goes to the pharmacy. Let's say they have a high-cost drug that they pay in March, and then they go back in April, and if they reach that, it's zero cost share. So everybody's happy. I can speak for myself and everybody else. Everybody's happy when they go to the pharmacy or the doctor and they say, "Oh, well, you've reached your max out of pocket. You don't have a cost share." So that's what the members are experiencing. And Connie, I'm sure you've probably got some positive comments on that from folks.
Oh, yeah.
Yeah.
I told them it was coming, and they're like, "Well, we'll see."
Right,
You know how they do.
right.
And then the next year I came back and they said, "We see."
Yes, we saw.
And it's a wonderful benefit Medicare gave us. That's basically they agree. And you know, it's all over the news anyway. A lot of that anymore. I mean, you know, they pass that around and it gets in the news, and so they hear about it other ways too.
Yeah, and I think we wonder what provider and prescribers, you know, behavior, and how that will change, or how member behavior will change. You know, will they choose a more expensive drug, or will a provider be willing to prescribe a more expensive drug knowing that there's a $2,100 cap? So a lot to be learned over the next few years in terms of what that means for changes in utilization, generic brand, you know, those types of things, which can have a material financial impact. So a lot to be learned in terms of what happens with this, because you've really capped what a member can pay in a year, from, you know, again, $8,000 to, you know, $2,100, and it'll be $2,400 and $2,700. But yeah. Next slide.
Yeah, we'll move on. So next we'll go into the financial review. So with this, just highlight the gain share agreement that we have in place with KPPA. We do agree to the service level commitments on the administrative services with financial penalties should we fail to deliver on any of those commitments. We'll get into the performance guarantees here. We can move on to the next slide. We can see here, just in brief, all of the performance standards around this plan we have met for the 2025 plan year. So all of the different metrics that we have in place were met. In fact, a lot of those were exceeded. So we'll continue with those efforts and work to do that year over year. So do just want to summarize that. We don't have to go through all of these. We can move on through these slides and then get to the benefit changes to consider. Slide 27. Thank you.
Yeah, Stephanie, I'll get this going. So as a part of our effort to try to be consultative, we're talking to, and every 3, 4, 5 years, I think it's good for us to talk about, you know, does a benefit change make sense? Is it appropriate? A lot of times plans will decide to do benefit changes if you know, like if the renewal is a little higher, maybe they can buy down the benefit. So when we make a benefit change, it reduces the premium. It's not taken by Humana. It reduces the premium. So if you make a benefit change, the premium would be, you know, reduced by that amount. And so we've had some discussions. We're having these discussions. It doesn't have to be in 2027. It could be for 2028. We're hoping that we're going to have a really, really great renewal for 2027. And so maybe that it doesn't make any sense, and maybe it's good to table those for 2028. But it does make sense to really talk about these, and you can see, you know, some increases to co-insurance, some changes. I will say some changes on increase on the Part B RX copay. We're seeing a lot of movement from Part D as in dog drugs to Part B as in boy. So that's moving drugs from the pharmacy side to the medical side. We're seeing a lot of that, and quite frankly, it kind of looks bizarre, because I think I don't know if it's doctor behavior, but it's more costly is the point. And so I think that's something that we've talked to our plans about. There's been some therapeutic injections, some eye injections that are very, very expensive that we've noticed on claims. And then also, you know, and Carrie brought this up, and Ryan too, there was a significant benefit enhancement with the IRA. And so does it make sense, and we talked to our plans, you know, does it make sense at some point, maybe not in 27, but maybe in 28, to pare back to pare back that benefit a little bit closer to what it was pre-IRA. And so what that really would represent is maybe adding a deductible on Part D. You would basically, if you remember, it was $8,000, and then it'll be $2,500 $400 in 27. Maybe you add a $100 deductible on the front end of that to have a little more cost share. You're not eliminating the entire benefit of the IRA, but you're reducing it a little bit. So, again, you saw on the slides where the member used to pay $800 or $900 and now they're paying $400. Well, if you add a deductible, perhaps the member would pay $500 instead of $400, where they used to pay $900. So anyway, just some things to think about. Again, I'm not suggesting any of these things need to take place in 27 or 28. We just want to be consultative and bring things to the table that we're talking to our customers about. Everybody has different dynamics in terms of what they're looking for. Again, I think the renewal may dictate some of this too. We're hoping we'll have a very good renewal to share with Ryan and Aaron and the team here in the next month or so. And so maybe these can be tabled for 2028, but we wanted to bring them up. Stephanie, anything you'd add?
No, I agree, Joe. I mean, given how rich the pharmacy plan was made as a part of the IRA, some of our clients are considering pulling some levers on the pharmacy side to help keep the member in the game, right, a little bit longer. And to Joe's point, they're still not paying as much as they were prior to the implementation of that in 2025. So things to consider, and we can talk about once we get your renewal on CA. But
Yeah,
when you'd have this.
I respect that. I mean, I guess Connie and I talked about, we had IRA that benefited the member, right? I don't necessarily see it as pulling back there. It's just more, we obviously had cost shifted to us, right? Benefit to the member. Just more like a long-term plan on where we want to go. Not to hit a member hard in any one year or just to react to that. So help me with that.
Yeah. Well, I mean, are you talking more of like a phasing in or?
Yeah, just more like a longer term plan versus just, we had this one-time cost increase that benefit. We don't want to just react to that, but we want to think about it long term.
Yeah, I think what we recommend is really adding a front-end deductible on Part D. And so that's what we recommend, because that will really effectuate kind of, I'm going to say, pull back the enhancement, I think, is what you're talking about. And so you can...
Want to be more strategic than just the enhance, but keep going.
But I mean, I think, that's the best way to do it, Ryan, and whether you want to phase it in as a smaller deductible over 2 or 3 years or something like that. But I mean, I think the problem is that you either need to add the deductible, okay, or you need to make some changes in the specialty tier, because that's really where it's happening. I think for us, we're recommending the deductible over changes to the specialty tier because we think that the specialty tier changes would be more disruptive, and that's not really what we're trying to do. That's not the idea. So I think when we can certainly take a look strategically and look at the whole plan. We can do some benchmarking. I mean, we can do anything you want to do in terms of, the plan changes are certainly at your all's discretion, the board's discretion, but we can do some benchmarking. You guys have a very rich plan. All of our customers have rich plans. I mean, that's the benefit of group Medicare. And a lot of our customers have very little interest in pulling back those benefits, but also understanding as costs increase, incremental changes do make sense. So we're happy to do some benchmarking, Ryan, or I don't know what other strategy you had in mind. I might.
Well, I get the financing, and I'm going to look to her for any of the benefits.
Sure. And again, I mean, hopefully the renewal is good, and then we could maybe postpone any of those benefits to 2028 when. So those are some of the discussions we also have and deliver around the renewal time, because that's really when the rubber hits the road, if that makes any sense. But Connie, we can do some benchmarking or anything.
Yeah, I think that's what you need to do and
Okay.
see what, and I'm thinking, and Mr. Piercy and Ms. Carver and Mr. Riley, that kind of an approach of looking at adding the deductible and then looking at the specialty tier. Those are the two areas that I thought might be a way to impact that and not and still look at the retirees having that savings they're getting, because they can also do this, and this is still available, I believe. If they have a bill in January that is really expensive out of pocket, for example, they can't afford that, would the deductible, would that be able to be spread over the 12 months of the year? So then they can make payments on it, and so it's not as cost prohibitive for that 1 month.
Yeah.
So they can get their medicine and pay. There's a program that
It's called the
Medicaid
MP3 program.
Yeah.
It
That would
came
help
into
retirees.
play. Basically, it allows you to more or less finance the cost of your specialty drug early in the year
So-
for members. It was a bigger deal for folks who had less rich benefits, right? So like if they had
We have a component of that.
yeah.
Of
So
course.
so
And I think some of those people might be interested. If you're doing this kind of approach, see about education on that benefit
Right.
along with it, to offer them a solution to their high cost
Carrie,
medications.
what was our participation in MP3? Was it around 10% of our members? I'm talking about group. Do you know?
So I don't have the exact number, but I think it was less than 10%. It was very low. It was very low for our total book.
There was a big uproar about this in terms of what they were worried about is people taking advantage of people and charging high percentage,
Yeah.
like a credit card, putting your drug on it and then owing more, and seniors being confused. And it was, I understood the concern. I know your sister agency, TRS of Kentucky, was very concerned about this. I think that what we found, and I think what we found is that the folks running the vendors were not predatory. I think that was they were worried about, because we didn't hear a lot of complaints. But that was the concern, is people be loitering around the pharmacy saying, oh yeah, you don't know anything. And then they get a bill and they're like, I'm paying 10% interest or something, and it would be bad. But there was not a lot of uptick in it. But again, for a plan like your all's and our group plans, because they're so rich, there's not going to be a huge cost share. But certainly everybody has a different financial situation, fixed income, but yes, it's available, Connie.
So that's
if we
still-
were to make a benefit change,
Because I
would
would
couple
think they would need, there's a group of people that need that. And
Absolutely.
then, because we track who's got low income subsidies, somebody
Right.
gets extra benefit on that, it wouldn't impact those because they get really lower drug costs than even our group does, because they're on it special. That's 300 to 500 people a year. That's not a lot, but those people that pay for their premiums is kind of who I'm talking about too, So that's the percentage that does that is, as time goes on, you may have some more of those that are paying, their benefit is not as rich after the 2003 law change for insurance. So they have a little bit different of a structure for cost.
So anyway,
Something like this
I think
would
it's a
help.
good discussion to just keep having, and just to, again, we just want to provide consultative guidance on things we're seeing in the marketplace, and a good discussion may not be applicable, may not be necessary, but we'll continue to have these discussions. We can do some benchmarking, Connie, to give you a better idea. You can see the top one was
that's what
on the
I'm
right
saying.
was $100, and that would be almost a $5, $4.77 decrease. And then if you, and again, some more material changes at the bottom, also with changing your tier 3 and 4 co-insurance, is around $8.26. So anyway, just we'll continue to have these discussions. It's just good to keep these in your back pocket to know, kind of if you need them, what kind of savings are there, and if it makes sense.
Or kind of the longer term plan.
Yeah, exactly. Yeah, exactly. 100%.
Not this year, but
Yeah, no, 100%. Yeah, no, I think that's usually the way it works. We start discussing them, and then a year or two later, everyone becomes more comfortable, and we make those changes.
Is there anything, Mr. Piercy, Dr. Carver, Mr. Riley, that you all would want to add to this, or questions you had, or would you be interested in seeing those type of benchmarking and looking at the data to impact, I guess, your decision will be in September. But as Mr. Cole said, and Ryan said, Mr. Barrow said, this could be looked at like in meetings, and we have one in October, then in February of next year, and then May of next year. So we can look at this in those meetings as, you know, for the possible future for consideration of anything like that. That's just the thoughts in this area. I just wanted to see if you all had any questions or comments.
I do not. Dr. Carver, Mr. Riley? Okay.
No, sir. No, sir.
Is that it for Humana?
We got one more slide, I think.
Okay.
So just renewal planning as we move ahead towards that here in the next couple months. Some key factors to keep in mind. Cost trend will affect, of course, we're working on that. Pharmacy cost trend we've also gone through today. Reimbursement changes, which we hit at the top of the presentation, and then the proposed benefit changes. So all these things factor into the renewal, and we'll be looking forward to that here in the next month or so.
Yeah, no, mid-June, and there was some segmentation of the risk scores and things like that. So we're looking, and hopefully, again, as I've noted several times, we're going to have a very strong renewal to offer KPPA.
Yep.
And that's our
That
presentation.
concludes it.
Any questions? Any other questions, comments?
Yep, looks like we don't have any. Thank you very much. And we will move on now to the representative on the Kentucky Group Health Insurance Board. I think Connie's going to speak to this.
Thank you, Mr. Piercy. And yes, this is the board that, one of the retirees that has been on the board, usually the KPPA board or previously KRS, would be a representative from the board and needed to be a retired individual. But this group is basically the avenue that we can discuss benefits that are offered to not just state employees, but to our non-Medicare eligible retirees. And there's about a little bit under 30,000 covered lives around these people that we have enrolled in these Kentucky Employee Health Plans. But this Kentucky Group Health Insurance Board was created by statute. It still is in place, and it does include one retired state employee from KPPA for a term of approximately 2 years. There's some information about a possible change they wanted to make. If you go on down, you can see those paragraphs that I'll let you all read. Mr. Powell, Mr. Jerry Powell, who was previously on the board, is still our representative with the Kentucky Group Health Insurance Board, but I am the proxy. I've been the proxy since around 2011. And I do want you to know, we added the two statutes, or I'm going to say Erin helped with this, but if not her entire document. I had a little bit of a review, but I have been active on this board, and the board that comes with it, there's actually two of them, but this was the one that we need to make a decision and appoint somebody if possible. If nobody's interested that's in this committee, I do have a volunteer that is a new board member. Mr. Larry Totten has expressed interest. He goes to these meetings. He's been going to them for a number of years. We do have a situation where we sit on the board. There's a report that goes to the governor every year in the legislative bodies that looks at what work is done. It does include the retirees, and our retirees are participating greatly in these benefits. We meet once a month. It is an in-person meeting. They don't do the remote meetings any longer after COVID. And so it's usually it's the latter Tuesday of every month. So I would like to ask the board to recommend someone for the KRS and the CRS full boards to ratify.
You're still willing to serve though, right?
And I'm sorry, yes, Ryan, I'm still willing to serve as proxy. I have been attending every month. And I really feel like our participation there has gained a lot of programs and inclusion in the retirees of this group of state active employees, because it took a number of years to get them engaged, but now it's working very well. They are active. We're seeing the reports, and this board member that you all recommend would bring back something to the committee if you wanted them to have a report every so often, because we do meet with them yearly, and we do get, the information about the renewal, which comes out in October. So I just wanted to present this to you and just ask for, I guess, a recommendation if you feel that is appropriate. Thank you. You have any questions?
Yeah, I know Larry's really interested in this. I've talked to him a couple times about it. So I will actually move that we approve Larry to take this position on this particular board.
And I second that.
Thank you.
Great. We have a first and a second. Any discussion? Seeing none, all those in favor?
Aye.
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 Any opposed? And that motion is adopted. Connie, it took a year, but you finally got somebody on the board after Jerry left.
Mr. Dorsey, I appreciate that. But I enjoy going down there hearing about our retirees. They have a great group working at the Department of Employee Insurance, so have to give them kudos for that.
All right. Good deal. Thank you very much. Okay, folks, we have reached the end of our agenda for the day. So there being no further business, I'm going to adjourn the meeting. Thanks for everyone's attendance, and we'll see you at the next one.
So long.